what I would say is that nobody really can understand as much about the human nervous system as the people that actually interact with it physically all the time. When you think about all the times we've been there, and I always tell residents, trainees, young doctors, junior doctors, and I'm mentoring faculty, etc., to just stop and think about what you're doing and
Yeah.
where you are.
Welcome, everyone, to our GNI podcast. Absolutely thrilled and honored to have Dr. Charles Liu as our guest today. Dr. Liu is a friend, a colleague, a mentor, all wrapped in one. He's technically a neurosurgeon, but he's a lot more than that. He's the Michael Apuzzo Professor of Neurosurgery, Behavioral Health, Psychiatry at Keck School of Medicine, USC, where he did his residency. He started off as a chemical engineer at University of Michigan, and went on to get his PhD at Rice in chemical and mechanical engineering, and then went on to one of the best neurosurgery residency training programs, USC, in its glory days. That's another podcast into itself. He is the head and director of the Neurorestoration Center at USC, and that's really what we want to talk about today. Is get into a little bit of, for our audience, and we know we have a lot of neurosurgery listeners, fellows, residents, but we have a pretty broad audience here. So I think I want to kind of take this to 30,000 feet. And you can't turn on the TV or radio or paper, read a paper, and not hear about AI, and everyone's talking about Elon Musk and Neuralink and all that. I want to kind of get a little bit more granular. And, the real history of this started decades and decades ago. And I would say it was stereotaxis, going back to the early days of localization. And, we're at a point now where I like saying we have, for the first time in the history of medicine, going back to when medicine was first called medicine, we have technology we don't know what to do with. So you remember when we were residents, it was, how can we safely get to this place? How can we, now it's not about localization. We understand all the neural pathways, tractography in humans, not in preclinical models at this point. And so now, in my mind, neurorestoration, which I love that term because that's something I wanted to ask you about. Back in the day, it was functional neurosurgery, which I always thought was so limiting. And for those of you that don't know, functional neurosurgery started where, one of the early things that we started to treat was Parkinson's disease or essential tremor, where it was a very well understood pathway where we could either stimulate or inhibit different pathways to stop tremors. From there, it's opened up into everything, and that's what we're going to be talking a little bit about today. So what are your thoughts on that? What is what do we call the old functional neurosurgery today?
Yeah, wow, Errol, I mean, you really covered a huge amount of ground in just your comments there. And there's so many parts of it that really requires that we do a slightly, a bit of a deeper dive. I think that, very often there's an observation that's made, and then this observation leads to hopefully, more questions. And if you start uh, diving deeper, you realize that your simple framework, and all these frameworks always start simple to begin with, right? Because you don't know that much, and you don't know what you don't know, and so you come up with a framework to try to allow you to make sense of what you've just seen, and then usually what happens is you start seeing things that are uh, you know, more complex than that. And, your framework doesn't allow you to fully understand it. And then you have to basically expand your theoretical framework to accommodate it. And, this is a very typical kind of thing that we've seen with, you know, um, so many things in humanity and science. And certainly functional neurosurgery and what we do is not any different. I think that the brain is exceedingly complex. Um, it you know, I mean, I think that the only parallel that one could draw would be space and the universe. I mean, you have 100 billion neurons that fire, and groups of them start behaving together, and you get these sort of local field potentials, and then you've got EEG that emerges, and then the combination of all of that can be understood in terms of, I suppose, behavior, and then ultimately the mind, and then you've got the emergent properties that come from lots of minds together that you call culture. I mean, it's a very, very uh, complex and probably one of the last remaining aspirational goals of humanity, right? Is to understand this. Um, Neurosurgeons have always played uh, a profoundly important, and I don't hyperbolize often, but profoundly important role in our understanding of all of this, because as you pointed out, you can't really begin to understand something without safely getting information out of there. And for most of the development of certainly in the human brain, the only people that had access to the brain in a living, behaving human were neurosurgeons. And so, in essence, our role has been exceedingly important. Now, the information that, so we've developed, as you pointed out, lots of ways to get to basically every part of the brain. I mean, and, again, I don't want to focus on the brain. I mean, we focus on the brain so much. And, I know many neurosurgeons are spine neurosurgeons, and, every day they're basically interacting with, the part of the central nervous system that we don't think about as much, and that's a spinal cord, which, by the way, Errol, existed before there was a brain, right? I mean, whether
Right.
you believe in evolution or
Yeah.
creation, I mean,
Well, embryologically, yeah. I
yeah,
mean,
it started off, right? And so, we interact, and you pointed out that we can now, using these various techniques, invasive techniques, open craniotomy, right? Talked about stereotactic approaches, which really emerged before the stuff that you guys do amazingly, which is to get to all different parts of the brain through the natural sort of highways, the endovascular approaches. But then this whole part of non-invasive, and so I think the comment that I have, the way I kind of think about this is that we neurosurgeons have had played a huge role in understanding how this amazing thing works, and we've done it because so much of our knowledge related to getting sampling it invasively from all different parts of the brain, and neurosurgeons have played a huge role in developing these techniques that allow us to safely get to these parts of the brain. But then it comes down to, okay, so now we can get there. What do you do with information, right? And then
yeah.
if,
So I want to, because I want to put this into buckets, because it's you have such a great perspective of this, because you're one of the rare. I'll be honest with you. I'm not blowing smoke up your ass. I mean, you're one of the only people I know that really have a foot on both sides. So I want to start just compartmentally with, because I know we always get a lot of these questions after in the podcast, especially from residents and medical students, and just really kind of at 30,000 feet again. You started off in chemical engineering, and then you went that path from. So I think a lot of people ask, how did you gravitate towards neurosurgery in particular? I think the functional aspect's obvious for your background and your interests, and just knowing you and how your brain works. But where was that connection from chemical engineering to neurosurgery?
well, I went to undergrad in Michigan, and when I started school, all of us have an idea of what you want to do with your life, and what I wanted to do was to solve human medical problems. And wasn't thinking about being a doctor. I mean, that was not really something that I gave too much serious thought to. I went to engineering because I felt like the way to organize your thinking around things, to make open-ended problems closed-ended problems, and then develop a technical solution. I mean, that's how human beings have solved all of our problems, right? So I didn't
Right.
see medical problems anything necessarily different. And at the time I started doing this, there really, biomedical engineering, bioengineering is massive. But when I started, this was actually kind of an emerging field. And so I studied chemie, which was one of the cornerstones of engineering, along with Mechie and Double E and civil engineering, chemical engineering. These are like the sort of the cornerstone engineerings at the time that I was going through. And then I decided to go to graduate school at Rice, because you know they before there was all this focus on the brain. There's a lot of focus on the heart. You recall, right? This is
Yeah.
before we're talking about replacement parts of the brain, we're talking about replacement parts of the heart with the Baylor Rice Artificial Heart Program and Michael DeBakey down in
Yeah.
Houston, and David Helms, my PhD director, was one of the lead engineers with Michael DeBakey on the Baylor Rice Artificial Heart.
I didn't realize that.
Yeah, yeah. So I went down to Rice and I did my PhD with David, and he was really one of the pioneering engineers. He and his colleagues, including Larry McIntyre, who was the founding director of the bioengineering program at Georgia Tech and Emory, the Coulter program, which
Yeah.
is one of the very top-rated programs.
So
Yeah, I
yeah. So
started.
so I want to, and I don't mean to cut you out because there's a something really important. That did they work? How did they come together? Did they work directly with DeBakey? Was there a lab? Was there? How did they connect? Because there's a question I want to ask you to follow up to that.
Yeah, so it was very funny because David Helms and I were very close. We used to hang out and play tennis together, and he was the dean of engineering at the time. And I asked him exactly that question. I said, "How did you get into bioengineering?" And he was a computational fluid mechanics person, right? He didn't know anything about bio. He wasn't interested in it, and basically, Michael DeBakey reached out to him as the
Huh.
way David described it, and asked to him and others. I mean, there were many others that I just talk about David because he and I were the closest, but asked him for help to
Yeah.
solve this problem, right? And this is a great point because this is exactly how I go about things now,
Yeah.
right? Because I start with a problem that I want to solve, and I have an idea of how to solve it, and I look around for people doing these technical things that
Right.
of course with a informed eye, right?
Yeah.
And then I bring them in to
Yeah.
yeah. Anyways,
That is really fascinating to me. And that this follow up question to that for you personally, how much clinical that was part of your programs, not what you did on your own, from your undergraduate at University of Michigan doing chemical engineering to your PhD at Rice. How much clinical experience did you have being, with a medical school, going to a clinic, going into the operating rooms, being in the hospital at all? How much experience did you have
well, I mean, in undergrad,
curriculum wise?
very little. I mean, from
Yeah.
undergrad to grad school, I mean, I didn't make the decision to go to medical school till I was almost finishing up my PhD,
Right.
right? And I had very little contact. I mean, I think this is part of the frustration. We worked with lots of physicians, but I never had any contact with patients. And then I saw, one of the things that David and Larry and that whole team, one of the major contributions is they basically, I mean, them and others, of course, but they contributed to the establishment of the field of cardiovascular mechanobiology. So we were constantly surrounded by people interested in thrombosis, hemostasis, everything that flowed that generated a mechanical signal and how it affected the biology. But I never had any real contact with physicians until I decided to shadow a hematologist over at Baylor. Um,
Which you did that on your own, right?
Oh yeah, no, I did that completely on my own because
Yeah. So,
these disciplines are very, siloed.
and that's a huge thing, and that's something that we've been discussing a lot about this now, about how we have to adapt the way we're teaching, for lack of a better word. At Drexel, we have a great biomechanical engineering school. I would say probably one of the the best well-known schools, and there we noticed that, and my wife Elizabeth, who was the dean of the graduate school, and we started talking about this, and so we started a program called Engineers and Scrubs. So we took the graduate students and the undergraduate students, and we brought them into the operating room, and it was like magical. I mean, for us as the neurosurgeons, because you could pick out the students that were the medical students and the engineering students. The medical students, and of course, I'm stereotyping here, but they were there. Yes, they were there. They were interested, but it was all about, I need a letter. I want to be a surgeon, or trying to figure out, right? Do I want to do this? Should I? That whole process that we all went through as third years. And the engineering students, they didn't give a crap about any of that. They were just laser focused, like sponges. Why are you using that? What's that clip made out of? Why would you use mesh here? Why do you need to? And it was one of those times where I was kind of like, huh, that's a really good question. I don't know. And well, what do you think? And we have to, I think, get back to that, and particularly in this field, and that gets into where we're siloed as neurosurgeons, and this is where I'm going to challenge a little bit, and I would say, and I'll make a statement, that I think we have fallen behind in neurosurgery, because you stated it earlier. Not that long ago, we were the only ones that had access to the brain for decades. And that was this magical, and now with everything that you're doing, that, endovascular, we finally caught up to, I'm going to put a little clip up here in a minute of the stent roads. Where we don't have to use arrays. We don't have to use, and is it in its infancy? Yes. But we can, through the wrist, drop a stent in the sagittal sinus to pick up electrical activity and do these things. But the thing that is, I think, frustrating, we've had this technology and the ability to do this for decades, and I liken it to Zoom was around as a entity 10 years before the pandemic. And, people, they kind of brought it out as a business idea, which made perfect sense. People can connect from around the world. We can have meetings together. You don't have to physically be somewhere. And nobody really, I mean, in general, the population, business, medicine, regular population didn't adapt to it. Then we were forced to use it. And all of a sudden it was like, wow, look at all these things that we can do now. So, I'm curious as to your thoughts of, and I'm going to ask you a question. What is the role, if any, of the neurosurgeon in neuromodulation today?
Well, I mean, today, massive. I think I'll start by addressing one of the comments that you made, and I think that it bears discussing. You talked about you and Elizabeth's idea of bringing engineers and medical students in the OR. I think that's super important. We're not that different. In other words, I'm an engineer, right? So I was an engineering student and I was a medical student. And in the end, we all want to solve the same problem. We just have different skill sets to bring to it, right? And I think that when you're describing the what people want to get out of it, there's always our aspirational goals, and then there's the clear and present danger, right? That we need to get done, and so the pressures that are put on people isn't necessarily an indication of what they're like. It's just happens to be the circumstances they find themselves in. Now, the big question that you asked, which is, what is the evolving role of neurosurgery going forward? It's very interesting because I've had many phases of my career. For 10 years after I finished residency, I was the busiest intracranial neurosurgeon at USC Keck. I did all of the surgeries that.
And that's a fact. That's a fact for the audience. I want to make it really clear. Charles is a hell of a neurosurgeon, and he is a practicing neurosurgeon, and he functions. That's why I said you're a very, very rare breed that does do both, can do both, but you have what almost all of us in neurosurgery don't have, and that's kind of what I'm getting at. You truly understand both sides, and I think the reason I'm putting it in this context is how do we get more young Charles Lus who are out there right now in chemical engineering programs and all that to say, hey, there's a whole world here, and you may not be thinking obviously that this is neurosurgery or any form of medicine.
Yeah, but, so in I think it was 2013, I worked very closely with Mike Apuzzo, as you know, and he was transitioning the role of editor-in-chief of World Neurosurgery. Mike had just done many things, but one of the things that, everybody kind of knows him for is his stewardship of the academic literature in neurosurgery. And so, of course, Ed Benzel is the editor, is doing a great job and taking the journal to new heights. But, um, having worked very closely with Mike, with our last issue that we did together, he actually asked me to write an editorial on any topic that I wanted to, and he said, this is your sort of your parting shot, if you will, right? Um, and I can't remember the exact title, but I it was on the relevance of neurosurgery, the evolving relevance of neurosurgery in medicine. And to be a little bit provocative, I put a question mark in the title because I thought it was a question that was really just being defined. And why did I do it that way? And it's because, as exactly as you said, there's what's a dog going to do when he catches the car, right? That he's chasing. In a way, we're kind of like that, right? We know that we need to get there, and we're developing all these techniques for treating real human disease. And again, I want to emphasize that what neurosurgeons do is super important because for the person that's undergoing a neurosurgical procedure, there is no more important person than than that this this person and no important endeavor um, than getting this done where you're actually treated. But now we're there, right? And so what I would say is that nobody really can understand as much about the human nervous system as the people that actually interact with it physically all the time. When you think about all the times we've been there, and I always tell, I residents, trainees, young doctors, junior doctors, and I'm mentoring faculty, etc., to just stop and think about what you're doing and
Yeah.
where you are,
Yeah.
right, and what the opportunities might be.
Right.
And I think that then what that means, Earl, this is important, right? What that means is because you have a unique perspective, only you can think about questions in a way. I mean, there may be questions that are begging to be asked that you simply don't. I mean, for example, why, to your specific example about the stentrode, why did it take so long? Right? We, have been doing this forever, and in fact, the areas of the brain that we're accessing now are actually some of the areas that are very difficult to sample. I mean, imagine I want to sample the inner hemispheric fissure of pardon me, let's say I want to sample for epilepsy, for example, right? The cortex on both sides of the inner hemispheric fissure. How do you do that? Well, I mean, you can do a grid, right? But that, it's a lot of microsurgery, right? You have to go in and do the dissection, and they're bridging veins, and you got to drop it. Okay, that's very painful. Um, and then you can do it SEEG, but what about at the very apex where the brain comes together to all the venous lakes, right? And
Yeah.
and all those bridging veins. So where do you drill your hole, right?
Right.
And so you think about what you guys do endovascularly. I mean, the superior sinus is one of the easiest places for you to go, right? And so there are these, and yet you're not thinking about it. You're not thinking about brain recordings. You're thinking about blood flow. You're thinking about stenosis, right?
Exactly. And
the point that I'm making is that, the people that are getting there are often the people that are best able to ask these questions, right?
But this is what I would ask you. Some do. I would argue that most don't. That most, even doing the most, skull, but where we're in God's country, as they say. I think most neurosurgeons are thinking about the surgery as they should be, staying out of trouble, understanding, where, but this, to your point, I think that's where we've been limited. You're thinking of, okay, how do I get here to do? You're putting those two pieces together for the whole. And I think, and I just want to pull up here just so we can, because I want to get some of your, so this is again, and this is for, I'll say this for the, for any of the students or residents out there. When I was we were starting out, I have about a quarter of the intelligence as Dr. Liu. And, functional neurosurgery to me always fascinated me. But I like the surgery aspect of it. And I would say right now, if I was a resident, I don't think there's any question I would have gone, I would go into functional neurosurgery. I mean, to me, this is the epitome of what we do. And, this digital motor output. And this is some stuff that my colleagues at University of Buffalo are doing. And to your point, these are, you got the motor cortex, the sensory cortex. How do we get there? I mean, it's how do we get there safely? And now this is what again this is not, to me, this isn't neurosurgery. This is what you and your colleagues have been doing. So here's an individual who is controlling his iPad and his phone with with electrical stimulation of his brain. And instead of putting grids and things like that on there, this is what we're able to do now, is to put a stent in the sagittal sinus that we traditionally have used to either, unclog drains, pull out clots, open up stenosed vessels. And, this design is something that's been, I can tell you personally, I mean, we did one of the first ones in the country. This has been around for a really long time. And I guarantee you, and you can speak to this, I'm going to stop the share here, is that your colleagues in biomechanical engineering, in chemical engineering, they're like, oh yeah, we could do this in a stent, no problem. So, again, how do we bring that together so we don't waste another decade?
Yeah, I think that's a great question. I can tell you from my, of course, I can't speak for everybody, but for myself, as I mentioned to you, I went to medical school in a way so that I could be a better engineer. I realized that you can't solve a problem you don't understand. And, the circumstances surrounding the problem is very specific and it's very complex because you look at the whole world, there's so many different circumstances. I mean, got issues like insurance companies, pairs, what the incentives are, et cetera, right? It's very complex. So, I just knew that there was no way that we were ever going to solve this unless somebody went to the other side and started to work with real intimate knowledge on what the capabilities are on the two sides, right? And so, and 2013, after I did, I mean, for 10 years, I did a huge amount of operative neurosurgery. I began to take a step back and think about what it is that I really ultimately wanted to do, right? And I felt like, continuing to go along the same path that I was going on, which was being in the OR literally all day, right? Wasn't going to be ultimately the best use of my time, right, for what I wanted to do. So with that knowledge, I took a step back. Now, you make a very good point. You should never be anything other than completely 100% focused on the task at hand when you're doing a procedure. And so to do that simultaneously is something that you really shouldn't do, right? So when you're in the moment doing that, you shouldn't be doing that. You shouldn't do nothing other than get the patient safely, get the surgery done correctly, and so on and so forth. But once you're done, you can start thinking, okay, what are the steps that we took, and what are the opportunities during those steps to, as a necessary byproduct of our surgeries, lead to a better understanding of this. Now, the you have to be really careful because I know a lot of people are super excited about the stentrode and so on and so forth, but having worked with a lot of scientific collaborators on brain computer interface technologies, right? Going from, single unit recordings to local field potentials, then ultimately to ECOG and EEG. That's the whole spectrum.
Hmm.
What you can do, what you can achieve in terms of any kind of control depends on what information you can extract out of all these different levels of electrophysiological information, right? And so, the fundamental limitation to technologies such as Stentrode is basically they're recording, with these transvenous stents. What we're recording is ECOG, right? And so, and people, you can just take a look at the BCI literature and look at what's possible with ECOG, right? And that's ultimately the at least one limitation. Now, of course, with complex AI techniques, the information that can be extracted from noisy data, if you will, right,
Yeah.
is increasing. But there are limitations in terms of where all of this is going to go. But I think that there's no question that safely getting to different parts of the brain and being able to extract information of any kind, and then using the complex AI techniques to understand what's in that signal that you're extracting, is the
Yeah.
future of functional neurosurgery.
So I completely agree. And one of the big you see the halo effect of your specialty. So there's Johns Hopkins. There's a new specialty in plastic surgery. There's neuroplastic surgery. A very talented plastic surgeon is Chad Gordon, who we've worked with, and I know you've done some work with some of the implants with longevity and. The implants to me seem like what everyone is focused on, at least in our world, right? In the neurosurgical world. And, putting in, the idea of, here's an iPhone and you have an operating system and, you have a battery and you have, where do you put that? And traditionally we've had these big bulky, leads and, things, skin breaks down. But what are your thoughts on the implants? Because the big thing right now is delivery. Whether it's a medication or an electrical stimuli, or ultrasound or near infrared technology, but being able to have a window into the brain. I'd love to hear your thoughts on implants.
Yeah, it's a great question, and I think it's a really um, nice segue from what we were discussing earlier, which is all these different ways of extracting information from the brain, from electrode arrays, which are intracortical microwires, to grids, to now transvenous stents and endovascular. Not just, yeah, I mean, I don't know that anybody's doing anything transarterial yet, but these are all ways of these are all invasive ways of doing it, right? And of course, um, there are ultimately three ways to understand how the nervous system behaves generally, right? One is electrophysiology, which is what we've talked about already. The other is functional neuroimaging, right? And
Yep.
third is neurobiology, right? So, biochemical sensors and things like that that can understand. These are the three techniques that we as a field have to try to understand the brain. Um, the electrophysiological techniques, other than EEG, right, are naturally invasive. And functional neuroimaging is super powerful, but 99% of it is in the fMRI scanner, right? And so, but take a step back and think about what that is. What you're doing with fMRI is really looking at blood flow changes, right? Bold signal changes.
Correct.
And you're a vascular neurosurgeon, so Errol, I mean, there are, I mean, in terms of measuring blood flow, there are so many better techniques than MRI,
Yeah.
right? I mean, Doppler ultrasound, for example, is a great technique. And so, if there are techniques that allow you to measure blood flow and not just Doppler changes, but photoacoustic imaging is combining photonics and acoustic physics to understand
Hmm.
changes in blood oxygenation, blood flow. That gives you a sense of the same type of information that we're hoping to get out of fMRI, right? But doing it in a much higher spatial resolution and temporal resolution situation. So if you ultimately want to apply these types of non MRI based function or imaging techniques to humans, the skull is a big problem, right? Because the
Right.
skull basically attenuates all this information. So, we've been working again always with lots of scientific collaborators on these techniques, and with brain computer interface, and just going back to that video clip that you showed, some of the most exciting developments in BCI are BCI related to functional ultrasound based brain computer interface. And this is the work that we've been doing collaboration with Richard Anderson and Mikhail Shapiro and Mikhail Tanter in FISMED in Paris. But these techniques are super powerful. Of course, it's in the infancy. Again, what kind of information are you getting, and what can you make out of the information? But been some really nice publications in the last year showing the feasibility of this. And so, how did we do this? I mean, we did this first. We did it with working with patients with hemicranies, right? Because these are, going back to how much can you do in the OR? Well, you
Right.
can't do much, right? Because you have to do the surgery. You
Right.
can't just, do anything other than do the surgery, right? And
Right.
so, but with the idea that patients are walking, talking, and behaving outside of anesthesia with basically a massive window, right, to the brain in areas that you can't even conceive of putting all electrodes to. I mean, it's an incredible opportunity, right? And so
Yeah.
we started doing some initial studies working with these patients while they're waiting for their cranioplasty operations. And so, of course, once you saw what you can do, then the obvious question becomes, can you put uh, you have to replace a skull anyways, right? And
Right.
so what kind of material can you use that allows you to extract this kind of information? And therefore, again, this very specific example is a great one, right? Because, if you're not a neurosurgeon, you're not thinking about this. There'd
Right.
be no way, right? In the same
Right.
way that the stentrode concept existed for decades. And then, only just recently, like somebody, a light bulb went off in the head and said, okay, well, by the way, we can record from this. And so it's these types of, and then of course, once you decide that, well, uh, I mean, imagine working with materials engineers to actually develop, um, you know, uh, implants that they're actually optimize a signal that comes out, right? So not just
Yeah.
that you can
That's
get signals, right?
right.
That you can
Yeah.
optimize the signals. I mean, the whole again in the infancy, but when you show people what's possible, then the field really starts to evolve. And so for us, several things. Number one, why do we work with uh, longevity and by the way, just to fully disclose, I have no conflicts of interest to disclose as far as longevity is concerned. We
Nor I. Yeah, no, it's a good point. Nor I. So everything we're talking about, I have zero conflict of interest with longevity or of any of the implant companies.
they're great,
Yeah, they are
right?
great.
They provided huge amounts of in-kind support for the work that we've done.
But what they've done, because I just want to pick your brain on here because it's like so great to have you for this time, and it's like I want to extract as much as I can. So we started putting in for exactly what you said. Is this we've been putting either the patient's own bone back. Or these implants that were nothing more than cosmetic, just cosmetically and obviously for protective purposes. But now, with a company like Longevity, where they're optimizing the same implant, but now allowing us to have that window in the brain. So I am almost all of my craniotomies now, whether it's a bypass, I can put in a handheld ultrasound to make sure the graft's open, a Chiari malformation. I never used to put implants in. Now I have this window that optimizes. I can see if there's CSF flowing around the foramen magnum as opposed to getting an MRI. Brain tumors, hydrocephalus. Now, is it in its infancy? Absolutely. But it's what is going to catch up is the ultrasound technology, is the imaging technology to say, oh, I didn't know we could do this. Now we can optimize this to this. So where do you think, and this is a big question. I want, and I think it's complicated, but where do you think these advancements, for lack of a better word, and to be very pedestrian, are going to come from? Is it our world? Is it the academic world? Or is it industry? And I know the easy answer is both, but if you look at where everything's going right now, I mean, that, just like we talked about the disconnect between engineering and basic science with clinical, I think there's this huge chasm between, because what we grew up with was, oh my God, if you're working with industry, it's bad. You're being paid off. They're flying you to so and so in a, first class airline ticket. They have the best engineers. They have the technology. They have the ability to do this. And we're the stewards that have to say, this is bullshit and this is just, either stupid or it's just something to make money, or, okay, there's something here, but this is what you need to do with it.
Yeah, I mean, so as you know, I came from two worlds. When I was an engineering student, um, relationship with industry, and if you look at the top engineering departments, just pick bioengineering. I mean, they're very proud of their relationships with industry, and they're able to, and then of course, as you pointed out with the doctors, the relationship is often construed in a different light, and I think that it really comes down to the very direct conflicts that may exist between when there's a patient involved. There's sort of direct and indirect, right? And I think that that's obviously a very complex question, and well beyond the scope of this discussion. But to your point, I think that it requires both. And how do you manage that, right? How do you manage the development? People very often conflate R&D, like R&D, R&D. R is very expensive and may not necessarily be in the purview of, commercial entities because
It's low yield.
yeah, it's super expensive, and in the end, that's not what the companies are there for, right? The companies really are there for development. When you have a uh, something that needs to be developed, then to develop with postdocs and essentially untrained, people, it makes no sense. I mean, the idea is that you get a guy with 20 years of experience who's done this before, right, to take it forth. Um, I think that the question that you asked is, how does some concept become reality, right? And I was actually asked this in 2018. That I was asked to give a talk on bringing advanced neurotechnologies into the clinic, and this was at the 2018 IEEE workshop that brain initiative workshop that was right before I believe the SFN in San Diego was held that year. Anyway, so and I, of course, I started off by, um, being a little bit provocative by asking, what do you even mean by into the clinic? An engineer who's working and you bring the technology near a patient, that's into the clinic, right? But I think that ultimately, if we want an idea to change practice and change the way the world works, that's where we want to go. In other words, it doesn't have it can't be just, oh, you can do it. It has to be, you ought to do it, because that's the standard of care. And that's when the things have changed. And I can see three major inflection points in this workflow from the time you have an idea to when something becomes expected practice. These three inflection points are: one, first in human; two, when you have regulatory approval of a product, which is the physical embodiment of that concept as it relates to an indication that the FDA, CE, wherever regulatory body you're talking about in the world is giving you a direction to go. And then the third is when things become commercially viable, right? And commercial success. In the end, it's binary in terms of the existence of a product that a doctor can give a patient, right? Which is, it's got to be sustainable. I mean, it could be huge, right? It could be massive. It could be worth billions of dollars, but it doesn't have to be. It just has to be, in the black. if you will, right? That
Yeah.
is commercially sustainable. So those are the three inflection points. And so, you know, I laid out a workflow and who the people are, and what their incentives are, what their challenges are, what their goals are, and
Or
it's
conflicts. I think conflicts are another important piece.
exactly. And there's so many, and this is why we see so little progress, right, from the publications you see in Science and Nature, ultimately to the way that you take care of your patients. And so the what I've been involved in many of these inflection points in neurorestoration, right, in regenerative medicine, neuroprosthetics, BCI, and in neuromodulation and task-specific practice, which is this optimization realm of the repair, replace, optimize trifecta, right? That really is a working definition of neurorestoration. And how's that? Why is that?
Yeah.
Because we're so good? No, because we basically made it our business to create these inflection points. You know, if you don't ever go first into humans, then it doesn't matter, right? I mean, not to us, not to patients, not to the field, right, of clinical medicine. So you've got to figure out a way. When you look at these really great scientific things that are going on, the first question you ought to ask is, okay, so what's your role in the team? So your role in the team is to figure out how to bring this first into humans. Because if you can't get it first into humans, then there's no point in discussing the rest of it.
But yeah, yeah, and so that's a really interesting point. And we're gonna wind up in a little bit here because again, I want to be respectful of your time for sure. But that is a very very important point because by its very nature, what we're doing with that and first in human is such a key concept because think about how many first in humans that we can do directly now because of all the things that you've and your field has helped develop. We don't need these preclinical models. And I'll never forget where I had this at Drexel. I when we first got there, there's a huge push university wide to get into really get translational medicine going. So I sat in in the dean's conference room with all the chairs of the basic science departments, and here I am thinking, I'm this great smart guy, and I'm gonna we're all gonna rally, and we're gonna cure cancer, and some of the things I was saying was, guys, gals, forget about NIH grants. Forget that's great. It's but there's so much out there. You're so focused on money. You're so focused on you take a typical graduate student who has this passion and this drive to come up with a cure or to come up with some type of, and it gets taken away because now all of a sudden it's a reality, right? As you know, as a PhD, well, I've got to get an R1. I've got to sustain my lab. So my idea and my passion starts to kind of go like this because I have to gear it towards whatever the government is saying this decade is. It's a decade of the brain. It's a decade of the heart. It's HIV. It's whatever we're going to throw money at. And it was really, it was amazing because I got sat down there and I said, what the hell did you say? You scared the hell out of all the chairs of the basic science departments. And what I realized was it was a huge threat because it was everything your lab and what you've based your career on, the way they perceived it was it's obsolete. We don't need preclinical. We don't need the basic science. And it was quite the opposite. It was, no, we need to bring these things together. We can do a lot, but you need to gear what you're doing. So what I want to do is I'm going to do in the last 5 minutes here, I want to do, so this is a Rorschach test. So this is going to be rapid fire. I'm going to ask you questions and I don't even want you thinking about it. I want essentially one word answers. So the first question I have is what you're the head of whatever it is now, AANS, CNS, and what name are you giving functional neurosurgeon? Are you staying with functional neurosurgery? What are we calling this within neurosurgery? If you want to do a fellowship in X, what is X? Is it neurorestorative? Is it neurosurgery? One word answer. It's
Neurorestoration.
okay. Love it. It sounds like we both agree that we need to change functional to something that's much more broad-based and encompassing of what, functional is today.
Yeah, I think that what's in a name? Everything.
Exactly right. Second thing, what is the number one what should the number one focus from a disease be with everything we've just talked about, with including AI? That's a hard one. But if you have unlimited resources, finances.
Yeah, I don't know that it's a disease. I think that, you think about the nervous system dysfunction. I don't want to make this a long answer, but there's three general categories. There's cognitive, sensory motor, and autonomic function.
It's Rorschach, brother. So you have Trump comes up to you and says, "All right, I hear you're the smartest guy in the world. I'm going to make sure that around the table, whoever you want in the world, brightest and the best, whether it's an engineer, a chemical engineer, it doesn't matter, unlimited resources. I'll give you whatever you want. Go back to Oppenheimer. You can have whatever you want, but you have to find a cure for one. It doesn't have to be a specific disease, but, put it in, epilepsy, Alzheimer's, cognitive. What would it be? And you can only pick one."
Yeah, I'd have to say epilepsy.
Okay.
Yeah,
And
and I say that, and I'll tell you, it's because that's how epilepsy has taught the world about the function of the brain, right? So I'm thinking about not just what we can do. I mean, it's a huge problem. The third most common neurological disorder worldwide, but it's what you're going to learn along the way, which is the
yeah,
reason I think we'd focus on it the most.
I think that's a brilliant answer. And I actually was hoping you were going to say that because one, it is I think, one of the most untreated. And all the things that we were just talking about, if you look at how many patients are truly surgical candidates, when I say surgical, not necessarily, amygdala hippocampectomies, but even through a stimulatory, and we are still stuck in the pharmacotherapy treatment of epilepsy. It's a massive number. And to your point, the amount of people from the pediatric population to the adult population is absolutely massive. But I think more importantly, to your point, we have so much. It is something that is very, and I certainly don't want to use the word low hanging, but I think with those resources, we could come up with a pretty darn close to cure for epilepsy.
Yeah, and also think about, we do surgery, right? We do advanced imaging, right? And we do a lot of really great neurobiological work, right? And so it's the only time human beings are ever going to get human brain from a live patient, right?
Yep.
I mean, so anyways, yeah. So you and I agree.
Yeah, every day. I mean, one of my first things that I did in the lab as a resident was take all the hippocampus, and it was like just they're throwing it to pathology. It's like, oh, mesial temporal sclerosis, and doing electron microscopy with it, just to say what's going on here. But anyway, well, listen, Charles, it's been an absolute honor and pleasure to spend this time with you. I look forward to seeing you with a scotch in hand so we can solve the world's problems as we've done in the past. Again, can't thank you enough. And listen, brother, keep doing what you're doing because we're all on your shoulders and your colleagues' shoulders. So
Thanks, Earl. Appreciate it, and good to see you again. Okay, bye-bye.
thank you very much.